And initially, these warnings were introduced because of the thalidomide disaster in early 1960s. So during that time, those who were exposed to thalidomide had the babies with all the deformities. So our concern started during those days, and we can't limit our caution for just for first 3 months of pregnancy, because these chemicals, like any drug, it's a chemical. It can affect any stage of the even before pregnancy also, prenatal as well as postnatal. Secondly, when a woman first learns that she's pregnant, the process of organogenesis, it's already started, it's begun. Like neural tube has already closed. Alcohol will cause fetal alcohol syndrome in the baby. Iodine, if it is given in overdose, it will cause reversible hypothyroidism. So if repeated analgesic doses of salicylic acid or NSAIDs are used, we have to be cautious, and we have to see the Doppler of the baby. We have to see the ductal flow. Also, we have to see the amniotic fluid. We have to keep a check on that regularly if we are giving a patient this drug.
Today, on behalf of the team Medflix, I am thrilled to welcome all of you to a session which discusses a very important topic: drugs to avoid in pregnancy. Pregnancy is a special physiological condition where drug treatment is concerning because the physiology of pregnancy affects the pharmacokinetics of medications used, and certain medications can reach the fetus and also cause harm to the fetus. Total avoidance of medical treatment is not possible, especially in cases where the pregnant woman may have pre existing medical conditions requiring medical treatment. But the question of the hour is, which medications should be avoided during pregnancy? To educate us on this important topic, we are fortunate to have Dr. Swati Gawai, who is an assistant professor and consultant obstetrician and gynecologist at LTMMC and CN Hospital, who has a vast experience in the field and multiple publications to her credit. Now, without further ado, I request ma'am to take us through today's session. Over to you, ma'am.
Thank you so much, Vamika. It's a nice, interesting topic about drugs to be avoided. And since all of us, most of the doctors also, as well as nowadays the patients also, they are very familiar that they have to take precautions during first few months of pregnancy. And initially, these warnings were introduced because of the thalidomide disaster in early 1960s. So during that time, those who were exposed to thalidomide had the babies with all the deformities. So our concern started during those days, and we can't limit our caution for just for first 3 months of pregnancy, because these chemicals, like any drug, it's a chemical. It can affect any stage of the even before pregnancy also, prenatal as well as postnatal. Secondly, when a woman first learns that she's pregnant, the process of organogenesis, it's already started. It's begun. Like neural tube has already closed, and the unborn child is already inadvertently exposed to the maternal drug during the early embryonic period. So, what are the stages? Like, first, the woman has menses, and then by 14th day, the ovulation occurs. Like, that's the ova releases the ovary releases the ova, and after that, within 7 days, the implantation occurs. That the embryo is formed and it gets implanted. Then the primitive streak is formed, then the neurulation occurs, like the brain develops, then the heart develops, then the extremities are formed, then the heartbeat is seen. So these are the various stages, and depending upon the stage where it is, the drug is taken or consumed, or the patient is exposed, like even for X-rays and all also, not just drugs. So depending upon the stage, it affects the baby's organogenesis. So before going to directly to the drugs, we'll just summarize what are the reproductive stages. So primordial germ cells, these are present in the embryo at about 1 month after the first day of last menstruation. And the oocytes in postnatal life, they are at in the arrested stage of meiotic division. the embryonal spermatogenic epithelium. It divides slowly by repeated mitosis, and then these cells do not differentiate into spermatocytes and do not undergo the meiosis in the prenatal period. And after the fertilization of the oocyte by one of the spermatozoa in the oviduct, there is stage of cell division and transport of the blastocyst to the endocrine where the lining is already prepared and implantation occurs. So after implantation, the bilaminar stage is formed and the embryogenesis begins with beating of heart and functioning yolk sac, which serves as a nutrition to the baby and the excretory organ also, which is then finally taken over by the placenta. So the next 7 days after these, there are finally balanced various microcellular events, which includes proliferation, migration, and association, differentiation, and the programmed cell death. And ultimately, it leads to the organogenesis of the conceptus. So during this period of organogenesis, there is the multiplication. The cells multiply very rapidly, and then there is cell migration. Various patterns are formed, and then the later stages. So the final morphological and functional development occurs at different times during fetogenesis, and it is completed afterwards. Postnatal adaptation characterizes the passage from intra into extrauterine life with tremendous changes in, for example, the circulatory changes, the respiratory physiology, etc., etc. So, what levels, what changes occur? Like if the drug is affected at the germ cell formation, then in females this oogenesis is affected, which is during the fetal developmental phase of the baby. The replication, cell division, egg maturation, at these levels it is affected in a female. Ovulation is affected. In males, this spermatogenesis is affected. Like gene replication, same. The stages are same. Multiplication is same. Form maturation, Sertoli cell influence, etc. So what happens because of that? The possibility of sterility or subfecundity, the quality of sperms is not good, or the ova is not good, or early menopause, and because of the hormonal changes, the ratio is also altered. If it happens during fertilization, like it will affect the oviduct, that is the fallopian tube, the secretions which are there secreted, the contractility of the tube, the various hormonal influences also. It will affect the uterus, the secretion, the nervous system, libido, everything. Same will happen for the male also. So the accessory glands, sperm motility, nutrition, hormonal influence on glands, the nervous system, erection, ejaculation, the behavior, etc. is affected in the male. Ultimately, it will lead to the impotence, sterility, subfecundity, chromosomal aberrations, and changes in the chromosome and the ratio, and sperm functioning also. So if it affects at the implantation, there is the changes in the uterine lining will occur and the secretion will affect, and ultimately this now henceforth the only female is involved. So what will happen if it affects at during implantation? There will be chances of spontaneous abortion or embryonic resorption, subfecundity, stillbirth, low birth, or preterm birth. If it affects during embryogenesis, like it acts on the uterus, the yolk sac, or placenta formation, or the embryo formation, or during the cell division, tissue differentiation, hormonal production, etc., etc. The same thing, abortion will occur, fetal loss, or the birth defects will start developing. Chromosomal abnormalities will occur, like at microcellular level, it will be affecting, and change in the ratio, low birth weight, etc. In organogenesis, how it will affect? It will affect the placenta, the transfer of the nutrients, the hormonal production, protection from the toxic agents. These are the functions of placenta, so which will be hampered. So organ development and differentiation. So same, birth defects, more chances of abortion, more chances of intrauterine devices also, growth retardation, and functional deformity is also there. If not the morphological deformity, and can cause carcinogenesis also. So during perinatal period, the fetus will be affected, growth development will be hampered, contraction because of the early contractions or more contractions, and because of the various hormonal levels at the maternal level. So premature birth, the or if infection is there, then various syndromes can also occur because of that. Postnatally, only the baby is affected, and it might affect the lactation as well. It will cause mental retardation and infant mortality, like within 28 days to 7 days, anytime, and various metabolic disorders also, and disabilities like cerebral palsy and epilepsy to the baby. So these are the various levels. So what are the basic principles of this toxicology? So there are main four basic principles. Like it is governed by the dose effect relationship. Like in small doses it might not affect, or in a large dose it will affect much. So the dose is most important, and the response of the dose by the mother is more important. So that is first principle. Second one is the it at it depends upon the species also. Like it will affect differently in monkeys, it will affect differently in other animals, in human beings. So it varies species to species. Third is that there exists a sensitive period, like at what period it affects of the development. If it is affecting during ovulation or during embryogenesis, or it is affecting in the third trimester. So it will depend upon that. And then finally is the pathogenesis. What is the cause? So what does it causes? It might cause, if it is affecting during ovulation, it will lead to infertility. Then after that, chromosomal genetic disorders, abortions, death, prematurity, low birth weight. So during late manifestation, growth retardation, fetal death, functional development, morphological development, and various other systems. Like certain drugs affect the particular system also. So system will be affected, particularly specific system will be affected. And during that susceptible period, if the insult means the damage, if the drug is consumed. So what happens in generally? What happens in the pregnancy? What is the pharmacokinetics? So for resorption, the motility of the gut is reduced, the lung functioning is increased, blood circulation in pregnancy is generalized increase. So about the plasma volume, it is increased, body water is increased, proteins are decreased, fat deposition is increased. What happens to the metabolism? The liver activity, it is almost same, or it depends upon the trimester also. Excretion, there is glomerular filtration will get increased. So during these, the passage and metabolism through the yolk sac and the placenta will change the physiology, whatever stage it occurs, the distribution, metabolism, excretion of the embryo and the fetus, reabsorption. So these things will affect the action of that drug. Because of pregnancy, the physiological changes also occur. There is almost 8 liter increase in the body water, which provides uh, a dilution in the body. Like the drug will also get diluted because of the increased water content. And the intestinal and cutaneous and inhalatory absorption of the chemical changes are also affected because of that. And there might be increased absorption from other areas also because of increased blood supply. So these proteins, they are also the concentration is changed. So the drugs which are bound to proteins, they are going to get affected. Some might get more absorbed, some might get not absorbed. So what is the mechanism? First is this receptor ligand interaction. So they interact. This whatever drug is there, it interacts. It can either it will help the mechanism, like it can be an agonist, it can be exactly opposite of that, it can be an antagonist, a partial agonist, it can act as a negative agonist also. So this is one mechanism. Second one is covalent binding. So it can bind, like forming a particular protein, or it can bind to a DNA. Then there can be peroxidation of the lipids and proteins. So they can so these chemicals exist, and they exist as the free radicals, and they generate free radicals during the metabolism. So they are very highly reactive, and they will oxidize the proteins and lipids and change the whole structure. Then they can interfere with the sulfhydryl groups also. So it will affect accordingly, like it can act as a catalyst, and they can inhibit the protein function. So it can be a catalyst, it will regulate the protein activity, micromolecular binding sites, like specific DNA binding sites, and it will affect the ribosomal proteins also. So many of the drugs, they interfere with the enzymes also. Like methotrexate, it mimics the substrate of dihydrofolate reductase and it inhibits the binding, resulting in the functional folate deficiency. So because of that folate deficiency, the patient will have neural tube defects. Then certain maternally mediated developmental toxicity is also there because of the mother. It is directly seen in the baby, and there are various other mechanisms like n number of mechanisms: DNA intercalation, interaction with unidentified targets, and various complicated interactions. So many interactions are there. So we'll just go through this whatever important things are there. And this is just the enumerated thing. Alcohol will cause fetal alcohol syndrome in the baby. Androgens, if given to a mother, will cause masculinization of the both the babies, but it will affect the female one. Anti-metabolite like multiple deformation, like methotrexate said just now I told. Then benzodiazepine will cause the floppy infant syndrome. Carbamazepine will cause spina bifida, multiple malformations. Cocaine will cause CNS, intestine, and kidney damage. If a mother is a cocaine addict, not in India, usually it is not common here, but in the Western world, it is seen very frequently. Coumarin anticoagulants, it would cause Coumarin syndrome. Diethylstilbestrol, it specifically affects the vagina, causing dysplasia as well as it can cause the neoplasm, the vaginal cancer. Adenocarcinoma of the vagina can be seen. Iodine, if it is given in overdose, it will cause reversible hypothyroidism. Lead can cause the cognitive development in the baby, like mental retardation and all. Methyl mercury will also cause the same mental retardation and cerebral palsy. Misoprostol, it will cause Mebius sequence, reduction defects of the extremities. The extremities will be small. Penicillamine, it can cause cutis flexa if it is given for a prolonged period. Phenobarbital, it will cause multiple malformation to the baby. Phenobarbital, phenytoin also, phenytoin syndrome is also there, multiple malformation. Then polychlorinated biphenyls, it will also cause mental retardation. Retinoids, topically also, and if they are consumed, then it will cause the skeletal defect, cardiovascular defects, CNS defects. The inner ear is damaged because of that. Tetracyclines, they cause the discoloration of the teeth. Thalidomide, that was the first disaster in 1960s. So multiple deformities, the extremities are affected, autism is there. Trimethadone, again multiple deformities and valproic acid. It will cause the spina bifida and multiple malformation. So these categories everybody know. I'll just summarize like what is category A, B, C. So A, there are well-controlled studies which have failed to demonstrate a risk to the fetus in the first trimester. So this is category A. So this is the safest one. Category B is the animal studies have failed, not in humans, but animals, it has failed to demonstrate a risk to the fetus. So it is a safer one. Like examples also I have given there in green, metformin, hydrochlorothiazide. Category C, animal reproduction studies have shown an adverse effect on the fetus and there are no adequate and well controlled studies in humans. But the potential benefit may warrant use of the drug in pregnant women. So we have to assess the risk and the benefit and give it accordingly. Category D is there is a positive evidence of human fetal risk based on adverse reaction data from the investigations or marketing experience or studies in humans, but potential benefit may warrant use of drugs in pregnant females. Category D is it has confirmed, it has shown that there is a positive evidence of fetal risk. So it is totally contraindicated, these drugs. So my presentation I've made like common conditions, common drugs, a group of drugs chosen. So these will be the titles henceforth. A group of drugs, and I am not just telling you the drugs which are contraindicated. We will first see what drugs are the safer one also. So for analgesics and NSAIDs, muscle relaxants, and this is a group. So here paracetamol is the safest drug. After that, NSAID, it should not be given routinely as an analgesic or anti-inflammatory, but it can be given if required if paracetamol is not working. Or this salicylic acid also along with NSAID. So if it is given for a prolonged period, like after 28 weeks, it may lead to premature closure of the fetal ductus arteriosus. So if repeated analgesic doses of salicylic acid or NSAIDs are used, we have to be cautious and we have to see the Doppler of the baby. We have to see the ductal flow. Also, we have to see the amniotic fluid. We have to keep a check on that regularly if we are giving a patient this drug for a long period, like 2, 3 tablets or for few days, it won't affect. If it is given for months and weeks and months, then definitely we have to check it. And if it is given in high dose, like 500 milligram of salicylic acid at the time of delivery, it can increase the chances of bleeding to the mother, the fetus also sometimes post delivery or during delivery. And low dose therapy of salicylic acid, it is safer without any limitation. Pyrazolamone, phenylbutazone, they should be avoided in pregnancy. And like already told, we have to monitor them by Doppler. We have to do their echo and amniotic fluid during these drugs if it is given after 28 weeks. And for analgesic morphine, these drugs should not be given preferably, but if the patient is having severe pain and we need to give the basic primary drugs, paracetamol, NSAIDs are not working, then we can give morphine, hydromorphine, and but with a limited for a limited period, and if it is requiring, then only. And once we give it, then we have to taper the dose also. Otherwise, what will happen, there will be withdrawal symptoms to the mother, and but if it is given just prior to delivery, then to the baby also it will affect. And how does it affect? It will cause respiratory depression to the baby, just if it is given just before the labor or before the delivery, either section or labor, whatever. So with prolonged exposure, the newborn may present with severe symptoms of withdrawal. In these cases, they should be referred to a center which is prepared for the ICU. Like baby, because of the respiratory depression, the baby might require ventilatory support. So such patients should be delivered in an institute. Pethidine, it is also sometimes it might be required for critical conditions, and then we have to check that the pre-existing fetal acidosis is not there. Otherwise, the baby will be hypoxic and the brain hypoxia may occur. So we have to check this. It is contraindicated, and especially for the preterm babies because they are not able to sustain labor and this pethidine also. So it can lead to ISD also. Then codeine, then it can be used as an analgesic if it is actually required, if the standard analgesic are not working. And it should be used in a short term only. It can be used as an antitussive also, like for dry cough if the other measures are not working. Oxycodone is also similar, and long-term use is to be avoided. And everything depends upon the dose, the timing, the duration, all the drugs. Everything depends upon that, and accordingly we have to check and assess whether we actually need to give it or we can manage it by giving the basic drugs. So under strict indication, we can give this fentanyl if it is actually required. Otherwise, we have to avoid all these drugs. Opioids also we have to avoid in obstetric analgesia. And we have to confirm that the fetus is good, that fetus is not in acidosis. We can check the fetal acidosis by the scalp pH. If she is in labor, we can take the scalp blood. So these other drugs, tramadol, buprenorphine, naloxone, this also can be given if actually indicated, and otherwise they are to be avoided. Ibuprofen is that can be given to the patient, and again we have to check for the Doppler if we are giving for a long period. And selective COX-2 inhibitors, they are contraindicated during pregnancy because of the effect on the kidney maturation and other kidney as well as lungs also. So continuous use, it can lead to it might prevent ovulation, and hence it should be avoided in peri-ovulatory phase also if it's an infertile patient and wants to conceive. So for migraine, the basic drug is metoclopramide, which is recommended. The other drugs like basic NSAIDs, painkillers, they can be given. If they don't work, then sumatriptan can be given, but we strictly avoid ergot alkaloids. in migraine in a pregnant female because it can cause contraction of the uterus and it can affect the baby also. It can lead to abortion and all. So for prophylaxis, we can give this metoprolol, propranolol, bisoprolol, and other acceptable drugs are like amitriptyline, PCA. But if these basic drugs don't work, definitely anti-convulsant drugs should be avoided for migraine, and same thing applies to these ACE inhibitors and all. Whatever other drugs should be avoided. Muscle relaxants generally they should be avoided, and the intervention if it is required, then basic anti-inflammatory are can be given, and if necessary, diazepam may be used for a short term. In this intrathecal baclofen, these are to be avoided. But if a patient is a case of a multiple sclerosis or post-traumatic spinal cord injury, then we might have to give such drugs to a patient. All patients won't be simple patients like. So that can be given for such special conditions like sclerosis and all. And for gout, this probenecid is the medication of choice during pregnancy for uric acid elimination. Allopurinol is contraindicated, and the exposure or other referred medication during the first trimester, there is no indication to consider pregnancy termination. If by unknowing the patient is not aware that she's pregnant, but we need not terminate such pregnancy, but we can do the investigation of ultrasound and all and go ahead with the pregnancy. Colchicine should be restricted to special situations, and long-term therapy it might be required in certain conditions like Mediterranean fever and all. It's not a routine medicine, and the therapy at conception or during the first trimester, it's not again an indication for termination. And same things, ultrasound and all can be done. These biological agents like this anakinra and canalizumab, they have shown efficacy, but they should be avoided. All biologic agents should be avoided during pregnancy. So for allergy and hyposensitization, H1 antihistamine may be used for the treatment of these allergic diseases during pregnancy. The safest one are the loratadine and cetirizine. And if the mother is having insomnia also and we desire for the sedative effect, then this clemastine can be given. And they should not be usually initiated during pregnancy. But if the patient is already on these medicines, then we can continue the medicine. And if the pregnancy occurs during the build-up phase, then discontinuation should be considered. And the maintenance dose has to be continued if the mother is already on that. Anti-asthmatic and cough medication like adrenergic drugs, they are given, and various inhalative drugs are also given. Basic like short-acting drugs are given, and long-acting formoterol, albuterol, all these drugs are given. So while we are putting the patients on these drugs, the inhalation one uh, don't affect much, but if we are giving them orally, then we have to be cautious about the beta 2 specific effects. And theophylline it might be given throughout the pregnancy, and to minimize the side effects, the treatment should be aimed for the lowest possible dose. Like we should start with the lowest dose, and if the patient is asymptomatic on that, then we can continue with the dose. Otherwise, we can step up little bit. So that other state drugs are this montelukast and opipratopium bromide, and this oxyprenaline and adrenaline, they can be used in emergency situation. If the patient is coming with an asthmatic attack, then we can use it. If she is not getting fever, we don't have time for the other drugs action. And this combination of drugs of this ephedrine, pseudoephedrine, phenylephrine, this should not be given during pregnancy. And used systemic use during first trimester is to be avoided, and if it is required, then we can again evaluate the pregnancy. The most common complaint of all the pregnant female from the first trimester is nausea, vomiting. So apart from all the drugs, we can give like basic like ginger and or some therapy like music therapy and all these things can be given. And if not, then the first and second generation antihistamines, they are the safest one. Doxylamine is the first choice, and it can be combined with vitamin B6. And nowadays, a good amount of doses, amount of 40 milligram per day initially, and maximum we can give them 80 milligrams, which is recommended. If vitamin B6 is not successful, then we can add antihistamine. And the doctor nowadays combination is also there, available a tablet in combination is there. And consider giving vitamin B1 also as an adjunct to this antiemetic therapy for prolonged hyperemesis, like if a patient is a case of twin pregnancy. So the chances, because of the excess of beta hCG, we can have more of hyperemetic, means more symptomatic. So we can give these things also. And if not relieved, then 100 to 500 milligram of intravenous thiamine. It's to be given 3 days and then maintained for like 2 to 3 milligram daily orally. Intravenous dextrose should not be given without prior administration of thiamine, as the metabolism of dextrose consumes the remaining B1 and it might worsen the symptoms, like the patient will be more toxic if it is given directly. So first we have to correct and give thiamine first. So for gastrointestinal symptoms, antacids are safer, and this combination of aluminum and magnesium salts is preferred. Sucralfate can also be used, and H2 receptor antagonist may be used during pregnancy. Ranitidine is the best investigated medicine, and it can be given. PPI, that proton pump inhibitor, they are prescribed during omeprazole is the safest one, and bismuth salts are relatively contraindicated, are avoided, they are not preferred. So for if IBD is there, inflammatory bowel disease, these drugs can be given. Mesalazine is the drug of choice, and this osalazine may be prescribed too. Sulfasalazine is more useful in case of extraintestinal manifestation. For steroids may be used during pregnancy, either locally or systemically when indicated. Azathioprine may be taken during pregnancy when it becomes necessary, and similarly, this mercaptopurine can also be given if required. Biologics, as already told, are to be contraindicated. Using infliximab and adalimumab are to be not to be given. The use during second trimester is assessed as they easily cross the placenta. So they can affect the baby very easily. This methotrexate and mycophenolate mofetil, they are contraindicated during pregnancy. Phenodeoxycholic acid, ursodeoxycholic acid during first trimester, that is the first 3 months of pregnancy, should be avoided. And if the patient conceives on that, then the medicine should be discontinued. And the only exception is if the patient is on is a chronic case of cholestatic liver disease as primary biliary cirrhosis. Then, considering the benefit versus the risk, we have to give this drug. And gestational cholestasis, it can be treated with ursodeoxycholic acid. Fenofibrates should be avoided in pregnancy. Statins for primary prevention should be discontinued when the patient is planning pregnancy. So those who are having severe metabolic disease, and we have to assess the risk and the benefit, and every patient is different. We have to decide accordingly. And if statins they are given for some secondary prophylaxis for cardiovascular event, then they might be continued during pregnancy. Like for cardiovascular system is more important than the baby. The mother's life is more important. Then we have to continue. So when it cannot be used, then we can use this cholestyramine. This, if we can't use this UDCA, then cholestyramine can be used. And if it is absolutely necessary, then may be used to lower a high lipid level. If given for longer time, then the supply of fat soluble vitamins has to be considered. Although this has to be taken at a different time, we can't take it together. A washout therapy may be conducted if leflunomide is used. So anti-infective means antibiotics. So it's a wide range of antibiotics. Most of the antibiotics are safer, and penicillin, it is a safe is if we give it for the heart disease patient, we can give it for a long time, and It may be combined with other antibiotics like clavulanic acid, sulbactam, tazobactam, etc. Cephalosporin is also safe, and whenever possible, we should preferably give this cephalo, cephalosporin, cephalosporin, and all. Aspirona, imipenem, and meropenem may be used if the above drugs or other basic drugs are not are resistant. Then we can use this drug. Erythromycin, clarithromycin, azithromycin, doxythromycin can be used during pregnancy if there is allergy to penicillin. And erythromycin estrolate, it should not be given during the second and third trimester to avoid hepatotoxicity. As already we know that pyrimethamine is the drug of the choice for this toxoplasmosis. So tetracycline, this is the drug which should not be given, and because it causes intrauterine device and various congenital anomalies and congenital cataract in the fetus exposed to tetracycline. So we don't know whether it is because of some other viral infection. Many a times it can be because there can be a combined two things, the exposure also plus some other infection also or some other genetic cause also. But it has been observed that those babies who had congenital abnormalities had taken oxytetracycline in the second month. The mother had taken it in the second month of pregnancy. So it causes these neural tube defects, cleft palate, multiple congenital anomalies, like affect the heart also. It can cause prematurity. So these are contraindicated. And to the fetus, it causes, if the baby survives and doesn't have this, then the chances of having this discoloration of the teeth is more seen if it is during the late trimester of pregnancy. So they cross the placenta and reach the therapeutic concentration in the fetal circulation also. And it is because of the deposition, the discoloration is due to the calcium deposits. And it mineralizes the zones of the teeth and seems to be pathogenically related to the pigmentation of other organs also. But this is more distinct. The teeth are more distinct. And it occurs when tetracyclines are used during the tooth formation. So they pass through the placenta and found in high concentration in the breast milk as well, and mineralization occurs. And the deciduous teeth take place from the fourth month of intrauterine life until 1 year after birth and continues for the permanent teeth up to the 7 to 8 years of pregnant woman after the third month of pregnancy. Nursing women and children under the age of 8 years should not be treated with tetracycline. So they should be avoided. Clindamycin and lincomycin should only be used when penicillin, cephalosporin, and macrolides have failed. So it should not be routinely used for the dental procedure also, and they are contraindicated after the 15th gestation, like from second trimester onwards only. So if really required, we can give it a local application of that antibiotic. And tigecycline also, if nothing is working, then only we can give it, and for a short period. Sulfonamide, trimethoprim, cotrimoxazole, these are the antibiotic of second choice. And if high dose of cotrimoxazole is used for a pneumocystis pneumonia during the first trimester, based on the theoretical ground, folic acid should be supplemented because folic acid is then deficient. So we have to give an extra folic acid, 5 milligram of folic acid is to be given. So the quinolones, they are the antibiotic which can be given. Nitrofurantoin can be given during pregnancy to treat the UTI, that is urinary tract infection, when the antibiotic of choice is ineffective. But we should avoid giving nitrofurantoin during the third trimester because, and especially if the patient is about to deliver, then we should avoid because it will cause hemolytic anemia to the baby. So these other drugs can be given methenamine, nitroxazoline, and nifluroxazide, niflotimax. All these drugs can be given, and fosfomycin can also be given. Nowadays, it is good drug, single dose, single sachet is there, 3 gram we can give it, and the patient also benefits well with it. But we should avoid giving it intravenously. Metronidazole, when indicated, which can be given 2 gram is sufficient, and instead of giving it parenteral is should be avoided, and we can give it orally or vaginally. Aminoglycoside should be used in life-threatening conditions, like if the patient is in sepsis and we need to give it, then we can give it. And the risk-based termination of pregnancy, again we have to decide, we have to evaluate, monitor. If she is an elderly patient who has conceived with an IVF, then we might go ahead with the pregnancy and do all the investigations like markers and everything. These glycopeptides, they also should be given only in a life-threatening condition, and this daptomycin is limited to cases of life-threatening bacterial infections. Parental use of cholesterol is also, so all these parental cholesterol, chloramphenicol, these are to be avoided. This will again, that will again cause gray baby syndrome. So it is to be absolutely avoided, contraindicated. But locally we can give it. During pregnancy, this dapsone should be reserved for specific dapsone we give in leprosy. So, if treatment took place in the first trimester, then we have to evaluate the baby. Otherwise, it will affect the baby also. So, for tuberculosis, ethambutol is the safest drug. Isoniazid is also a good drug, and it can be combined with pyridoxine and to treat active TB. Rifampicin is also good. It is safer, and when used near term, the newborn should receive. Anyways, we give vitamin K to the newborn as a routine procedure, so it should be given. And for other infections, we can use it, but streptomycin is contraindicated because it is ototoxic, so it damages the inner ear of the baby, so it is to be avoided. And if there is an inadvertent exposure during the first trimester or during organogenesis, then MTP as such is not required, but it's up to the patient. If the patient wants, if she opts for it, then we can go ahead with MTP. And if she wants to continue, then we can monitor by same ultrasound and markers and all other things. And usually the externally used antibiotics, they are not teratogenic, like local application, topical application. They usually don't cause teratogenicity, and this can be used safely, these drugs. So this artemisinin, this can be used in second and third trimester. In the first trimester, they are to be avoided during malaria. And this atomoconone may be used as a last resort in malaria. Chloroquine may be used throughout the pregnancy at any trimester for prophylaxis as well as treatment. It is very safe, cheap, easily available drug, and if only the resistance is there, then we might think of other drugs. Halofantrine is to be used in cases of acutely threatening malaria that can't be managed with other drugs. And when cardiac problems are an issue, other anti-malaria medication may be used. Lumefantrine, it may be used as a last resort. Mefloquine may also be used throughout the pregnancy for prophylaxis and treatment of malaria. So these are the safer drugs, mefloquine and chloroquine. Primaquine, it is not a therapeutic option during pregnancy, and prophylactic elimination of hepatitis post should be usually postponed for a time after birth. Proguanil used throughout the pregnancy for prophylaxis as well as treatment. Pyrimethamine, its combination of sulfodiazine may be administered during malaria. For toxoplasmosis also we can give pyrimethamine. And quinine belongs to the drug of choice when dealing with chloroquine resistant malaria, though it is a toxic drug. But then we have to think about the mother first. So the potential risk of treatment is much smaller for the fetus than the danger of a severe maternal disease. So we have to think about the mother in such depends upon what condition also we are using these drugs. So we have to pay attention, and we have to monitor the maternal sugar. She can have hypoglycemia. And the endotoxic effects due to quinine in analgesic compounds are not to be expected. These agents should be avoided. Fluconazole, itraconazole, they should start after the first trimester, and means like second trimester onwards we can give. And if the exposure occurs, then again depends upon the patient's condition. If she wants continue or not continue, and we can monitor and go ahead. If she wants, if she opts, then we can terminate. It's not nothing is fixed in. such conditions. It's not in category extra. So then the other drugs, cotrimazole, miconazole, and they can be given locally also. Amphotericin B should be used only in very seriously disseminated fungal infection if required. And these liposomal formulation, they can be given, and the amphotericin B can be given locally safely. Flucytosine should be used for life-threatening disseminated fungal infection, and it is not indicated as a monotherapy. It has to be given along with some other mycotic drugs. Grisophilbine is also is to be used during life-threatening fungal infection, and it should be avoided during pregnancy. And if required, then we can monitor if she wants to continue. Terbinafine, it should be avoided, especially during first trimester. And topical application is usually safer compared to oral. Nystatin, cotrimazole, miconazole, is an antifungal drug of choice during pregnancy. Whenever and wherever we want to give, we can give it. And the external treatment with these other drugs, it should be avoided. These drugs, morphine, buprenorphine, cyclopyrrolol, haloprogen, natamycin, naftripine, these should be avoided. Mebendazole can be given to treat the worm disease. Albendazole can also be given in echinococcosis, and other benzimidazole and antihelmintic can be thought of if these basic drugs are ineffective. This ivermectin, it can be given in pregnancy, and at first trimester, we have to evaluate if it is given in first trimester. MTP is not advised. Niclosamide can be given to treat the tapeworm, and during first trimester, it needs to be. We have to assess the tapeworm infections are not a great hazard to the mother or the unborn child. If praziquantel should be given only for the severe cases of schistosomiasis. Diclofenac and oxymethylphenol should be avoided during pregnancy. And if an antiviral therapy is required for any viral infection, then acyclovir and valsaclovir should be used as the first line. And other antiviral drugs can also be given if these one are not working or are ineffective. When indicated, then we can give local remedies for herpes during pregnancy, like topical application and all. And it is a preferred drug, this acyclovir. We give it 5 times a day. Ribavirin and other drugs can be indicated, can be given if the basic drugs are not working, and during the first trimester is not. If nothing is working, then we can go ahead with such drugs also. This neuraminidase inhibitor, oseltamivir, and tenamavir. Like in COVID, we had used all these drugs. So vaccines also, I'll just tell in brief whatever vaccines. As we all know, the live vaccines should be avoided during pregnancy, but there are certain vaccines which we can give during pregnancy. So if the patient is not protected, then we give this tetanus vaccine, and now it is Tdap that we give this diphtheria and pertussis also, and that can be given to a pregnant female, and if she is at risk of hepatitis, then that can also be given during pregnancy. This HPV vaccine, like we all know that Gardasil 9 and Cervarix. So Gardasil plain is there covering 4 variants, and Gardasil 9. It should not be given during pregnancy. And if if the patient is unaware that she's pregnant and she takes this vaccine, then MTP is not required. Can continue with the pregnancy. So it is not such not very alarming. So for flu also, if she's not vaccinated, we can give other flu vaccines also, influenza or during any trimester. So the other vaccine should be administered during pregnancy because this is theoretical. It should not be admitted because of the risk to the baby. But if the risk to the mother is more, then we can give the vaccine. If required, then we can give this meningococcal vaccine also to the patient, to the pregnant female. And pertussis already we are giving in combination, and pneumococcal vaccine also we are giving And pregnancy is not a contraindication for a polio vaccine. Nowadays, we don't give it, but this inactivated vaccine is there. Oral polio we don't give. This the injectable is also there, so it can be given. Uh, for rabies, it is also a live vaccine, but considering the lethality of the disease, if a pregnant female is bitten by the suspected rabid animal, then we should give the vaccine. And rubella vaccine, it should be either given pre-pregnancy or before, during normal immunization schedule. If it is not given, then we can give it before pregnancy. And other, if the patient finds that she's pregnant, then post-pregnancy we can give it. And there is a risk of embryopathy because of the vaccination, but then we have to assess the benefit against the risk. And termination is usually not required. Again, it depends. Varicella vaccine, it should not be given during pregnancy. Yellow fever is also not recommended. And if the patient is about to go to an endemic region, then we might have to give that vaccine to her. Immunoglobulin also should be avoided, but if required, can be given. So the drugs which are given for heart and blood, this alpha methyl dopa is the safest drug, and it is the first drug of choice for hypertension. Then beta receptor blockers, we can be like metoprolol, labetalol, they can be given second choice if possible. Then atenolol we usually avoid, and because there is a risk of prematurity, small for gestational age, and IUGF, that's growth retardation. And if the treatment continues during labor with any beta blocker, then the perinatal effects may be encountered. Post perinatally, like hypoglycemia and decrease in the pulse frequency to the baby. So after methyl dopamine metoprolol, these calcium channel blockers are the safer drugs in hypertension during pregnancy. Nifedipine, most of that, and it can cause the oral administration brings down the blood pressure very rapidly, and that is why it should not be given with magnesium intravenously. It will also bring down the heart rate. ACE inhibitors, they are contraindicated except if it's a severe condition which is not responding to other drugs, then we can give the medicine, but then again weighing the risk against the benefit. And if it is accidentally given, then we can continue the pregnancy and monitor the pregnancy. So if it occurs for the longer time during second and third trimester, then we should check for the liquor, amniotic fluid, because the chances of oligohydramnios are more. And the baby should be watched for the baby's renal function and hypotension. Angiotensin receptor blockers, they are also contraindicated again for the same similar mechanism, like severe growth retardation and all. So we can continue monitoring the Liker and all on ultrasound. Dihydrolysine may be used for gestational hypertension and intravenously even in the hypertensive emergencies. It is not first line drug, but we can give it if the other drugs are not working. So this urapidine IV, it is useful during emergency if all the drugs are not working, and prazosin should only be used during second and third trimester if the first one, the other drugs are not working. When alpha 1 blocker have been used during first trimester, a follow-up ultrasound has to be given. Clonidine, this maxonidine, this zerpine are no longer, they are not preferred for hypertension. Phenoxybenzamine may be used for the treatment of pheochromocytoma during pregnancy. This sodium nitroprusside should be reserved for selected cases that can be managed otherwise. These drugs, diazoxide and minoxidil, are not to be given. As these antiarrhythmic agents, they can also trigger arrhythmia in the baby. They are to be used cautiously, and the medication of choice for the class 1 is clonidine, class 1B is lidocaine, class 1 is propafenone, and also in the second and third trimester, Teratogenic. In class 2, well-tested beta receptor blocker should be preferred. Class 3 antiarrhythmic drug is required. Sotalol should be given. For class 4, verapamil and diltiazem are acceptable. With the also adenosine. Diuretics usually are not required during as a treatment for hypertension in pregnancy, and this if required, then hydrochlorothiazide is the drug of choice. And furosemide may be used to manage the heart and kidney failure. And for longer treatment, it is necessary to monitor the electrolytes and hematocrit levels, and to exclude the development of oligohydramnios. So when if the treatment continues until birth, the newborn needs to be observed post-delivery for hypoglycemia, and the diuretics are to be avoided, and none of these medications justify a risk-based termination. So we can continue the pregnancy. So anticoagulants, heparin are appropriate indication. If it is there, then we can give heparin. And nowadays we prefer giving this LMWH or unfractionated heparin, that is low molecular weight heparin. And if there is a heparin intolerance, like if thrombocytopenia is there or if resistance is there, then we can give danaferol as an alternative anticoagulant to it. The potential for increased bleeding is important consideration prior to any surgical. Like if you want to post her for cesarean section, then we have to think about giving it and we have to stop it. At least heparin LMWH, we have to stop 6 hours prior to surgery. Protamines, they can be used in during emergency in case of heparin overdose, or if we have given and the patient is gone in labor and if she's bleeding, then we can give this. And the chronic use during pregnancy is not recommended, and there is no such data of usage of this drug. And caution is required when using thrombin inhibitors prior to surgery or during intrapartum period also, because of the increased risk of maternal hemorrhage. So these are also associated with small but increased risk of embryopathy. So patients who are on VKA are primary of planning a pregnancy should be replaced with heparin, LMWH mostly. In the high-risk patients with mechanical heart valves, an exception may be necessary because of the risk of valve thrombosis. And oral anticoagulants throughout the pregnancy until near term may be essential, and the risk of fumarine embryopathy is small, so we have to assess the risk. And close follow-up is to be taken, and we have to check for the heart condition of the baby also because of that. So we have to, the baby should receive vitamin K, and the mothers who are treated with this, like carbamazepine, phenobarbital, phenytoin, primidone, rifampin, fumarine derivatives, the parental administration directly after birth is advised, and the neonate should be given at least 1 to 2 milligram vitamin K orally 2 to 3 times a day for the first few weeks, like first 2 weeks. Urokinase and alteplase should be used during pregnancy in life-threatening condition. Retiflase, tenecteplase, and all these drugs should, when this, they are theoretically superior, but they should be avoided. And due to the danger to increase blood loss, especially caution is to be taken while using these fibrinolytic drugs during the intrapartum period. And streptokinase, it can be used in life-threatening condition during pregnancy, and but we have to see for the bleeding also. We have to check for the bleeding also and keep it in the mind, and keep everything ready to manage such bleeding. Anti-epileptic drugs, most of them are teratogenic, should be avoided, and the potential for a contraceptive, if the patient is already on anti-epileptic, then we should advise contraceptive to her. And prior to discontinuing a contraceptive regimen, the anticonvulsive therapy should be optimized with consideration of embryotoxic properties. And woman who is suffering from epilepsy needs to know that the risk of major malformation increases 2 to 3 folds when using any anti-epileptic medication. So, valproic acid should be avoided in women during the reproductive years. And if only thing, if it is other drugs are not working, then she can continue with those drugs. So monotherapy is usually desirable, and low dose we try to keep the dose low, and then if not working, then we can step up the dose. During organogenesis, the medication should be kept as low as possible, and it should be distributed in 2 to 4 divided doses during the. And determination levels of free unbound anti-epileptic agents in the maternal blood should be performed. Like we have to check the levels of the drugs in the blood of the mother. And clearance increases during pregnancy, especially with lamotrigine and levetiracetam, requiring a higher dose adjustment to a lesser degree. This also applies to this of carbamazepine, phenytoin, and carbamazepine. If under anti-epileptic therapy, a child has been born with an anomaly that can reasonably be attributed to a drug and alternative anti-epileptic regimen. She is already having such a child, then alternative drug should be given. And if the mother and child have a higher risk of recurrence in a subsequent pregnancy, if the same anti-epileptic agent was used, so we should change it. 15% chance of recurrence is there. So if there is an indication, then clonazepam can be given during first trimester, and if long-term therapy has been instituted, especially during the last trimester, the newborn should be observed for possible symptoms. That is for few days, 2 to 3 days. The same for this clobazam and clonazepam also. Lacosamide is not indicated, and treatment in the first trimester is to be avoided. Second, third, we can give it, and there is a high risk of malformation. Lamotrigine is currently the anti-epileptic medication with the largest amount of data that appears not to be conserving. So it is comparatively safer. If applicable, it should be preferred when a pregnancy is planned, as neither animal. So there are no like it's category B. So if valproic acid is conduct, especially if valproic acid therapy is conducted, a change to lamotrigine should be tried in such patients. If epilepsy necessitates therapy and is well managed with levetiracetam, the medication may be continued. And if it requires treatment and is well managed with oxcarbazepine, then it might be continued. And combination should be avoided, especially during first trimester. So malformation usually occur, and we should, if the mother is already on that on the safer drug, then we should continue. And if required, we can change it. If she is on the valproic acid and all, we can change it to a safer drug and try to keep the dose as low as possible. And this primidone should be assessed prior, similar to phenobarbital. If a new treatment is started, then phenobarbital and primidone are not the drug of choice for women in their reproductive years. Treatment with barbiturates during the first trimester does not justify termination of pregnancy. So, with lack of relevant experience, this pregabalin it cannot be recommended during pregnancy, and combination should be avoided. If required, then topiramate can be given. So these are the, again, I have just summarized what are the organs and the anomalies, like neural tubes. What happens to the neural tube? It leads to spina bifida and encephaly. For the heart, it causes VSD, ASD, stenosis, ductus arteriosus, and pulmonary artery tap and all top. Extremities, it can lead to polydactylic left hand, overlapping of the toes, or hypoplasia of the ulna, tibia, and missing fingers, oligodactyly. Urogenital tract, it causes hypospadia, renal hypoplasia, hydronephrosis, duplication of the renal collecting system. For CNS also, it can cause hydranencephaly, coronencephaly, arachnoid cyst, cerebral atrophy, agenesis of the corpus callosum, septum pellucidum aplasia, all this Dandy Walker syndrome. Eyes also, it can cause cataract, the nerve hypoplasia, anomalies of the lacrimal duct, and defect in the cornea or cloudiness. To the respiratory system, it can cause hypoplasia of the lung and the laryngeal hypoplasia. Then abdominal wall, usually is omphalocele, gastroschisis, all these things are there. To the skin, it can lead to hemangioma. So valproic acid is more toxic during pregnancy than any other anti-epileptic agent. It should be avoided, and it increases the risk of malformation by 2 to 4 times. So if the patient is already on that, we should change it. And if a baby is having that, the risk of having another baby is increased. If it is already on valproic acid, then the chances are increased. So the daily dose should be, the patient should be shifted on safer drug, and the daily dose should be below 1000 milligram, and it should be distributed evenly. Psychotropic like this SSRI, serotonin reuptake inhibitors, they can be given. TCA are also studied, and they are useful if the woman is not responding to SSRI. And the advantage is that the serum levels are associated with the likelihood of response. So we can measure the serum levels and determine the response. So monitoring is also possible with that, and it helps in uh, keeping the dose adjustment and maintaining it. So with atypical antipsychotics, this clozapine, olanzapine, there is a chances of weight gain, hyperglycemia, glucose intolerance in pregnant female, and always we have to inquire about the alcohol and cigarette and other drug use during such patients for like these psychiatric patients. And the CNS, GI, respiratory disturbances, they have been described in newborns exposed to these antipsychotic drugs. So the adaptation disturbances are usually limited, and some infants have extrapyramidal symptoms also if the medicines are continued for weeks or months. So the classic antipsychotics such as butyrophenol and phenothiazine, thiazanthines may reduce the fertility via increasing the prolactin. And with exception, sulfuride, risperidone, are typical antipsychotics do not increase the prolactin concentration. So the lithium level that is efficacious with manageable side effects can be used as a level to target the low dose adjustment as pregnancy progresses and renal clearance increases. And we have to supplement them with folate so that we will avoid neural tube defects. And half of the pregnancies are unplanned, and so the supplementation is not possible. And early supplementation, as soon as we get to know it, then it will help. And after exposure to lithium in the first trimester, we have to see the fetal echo. Apart from the basic all anomalies and all, we have to focus more on the heart to see the fetal cardiac development. And the frequency of dose should be increased to avoid large rapid increase in the lithium serum levels due to the too higher dose administration, unless the compliance will be reduced. And if there is a loss because of dehydration or emesis or diarrhea and all, then we have to check the levels, serum levels frequently to reduce the risk of toxicity. So this renal function also, it can be impaired, and it can occur with preeclampsia, and the results with increased serum levels and dose adjustment and discontinuation should be considered in such conditions. And the clearance declines rapidly after birth, and the dose may be discontinued 24 to 48 hours once the patient delivers. Even if vaginally also or by cesarean also, then we can reduce the dose, and we can restart it after pre-pregnancy. We start the lithium at the pre-pregnancy dose, like it can be smaller. Benzodiazepines, they are also the drug of choice for the anxiety symptoms and can be given. And depending upon the half-life, the possibility of dose reduction should be considered with the mother before the expected date of the birth. So the agonist may be briefly prescribed during pregnancy, and regular use can cause adaptation disorders in the newborn. Like if the mother is continuously throughout on the benzodiazepine, then it can affect the baby also. Like the sleep disorders are there, and like the sedating antihistamines and trazodone, amitriptyline, and if necessary, these are preferable to the benzodiazepines. And if stimulants are used, then the expected benefit which outweighs if the mother actually requires stimulants, if she is very depressed, like my major depressive disorder, then we have to give those drugs also. And with anti-Parkinson drugs, it may be necessary during pregnancy, for example, in the context of therapy for a prolactinoma with ergotamine derivatives or for the extrapyramidal side effects, then we have to go ahead with it. And it can cause this restless leg syndrome, and cabergoline or levodopa are the reasonable choices for that. Immunosuppression should be usually avoided, but then if required, like, these are the safer one, azathioprine and 6-mercaptopurine. They can be given if accidental exposure occurs, then we can continue the pregnancy depending upon the patient's wish and the preciousness of the pregnancy. And if the tacrolimus use is also, if it is if the patient takes tacrolimus, then the newborn's kidney function has to be checked, and we have to check for the electrolytes. Similarly, for ADA, it does not need to be stopped when planning a pregnancy, but in second and third trimester should be reserved for well-grounded indication. Means it should be avoided. If we can replace it with some safer drug, then we can give this adenosine diamide. And those who have that, they should be immunized with a live vaccine before 6 months of the life in these children. And discontinuation is mostly recommended by at least 30 weeks. So though teratogenicity is not seen, but all these drugs, etanercept and all these drugs, they should be infliximab and all. They should be avoided because ultimately they will also bring down the immunity of the mother and they can cause sepsis or the opportunistic infections will be increased. But again, you have to assess the risk versus the benefit. And the decision again is depends upon the condition of the patient. If she's actually requiring it, then we have to give it, or we can, if we can delay it like till delivery, then it is better if we delay it. Like if it is detected during the late trimester, like in 7th or 8th month of pregnancy, then it is better to delay it for few months and then start it once the patient delivers, or deliver her early and then start it. Like preterm also we can deliver and start it early. Basically, all these drugs are to be avoided. I think I have crossed the time. Vamika, can we continue? I have 2 more slides.
Yes, ma'am. I know we are over time. Audience, doctors, if you're all okay with continuing, please give us thumbs ups and hearts. All right, ma'am. Well, ma'am, we can quickly maybe take 10 more minutes and then take few questions as well.
Yeah, the questions also we have. So same for the anti-neoplastic drugs also. If just now I told you that we have a waiting period of 2 years for a woman and 6 months for the man before conceiving. If she is already on these anti-neoplastic drugs, then it is preferably if to avoid pregnancy at least for 2 years. And if a man has like nowadays we are considering these things also. I kept my last slide that for like though we are a gynec, I'm just kept the slide for the males also. Like we should think all this spermatogenesis and all occurs in male also, which forms a major part of the embryo. So, for a man, it should be a period of at least 6 months. And if required, if it is an inadvertent, if it's an unplanned pregnancy, then then we can continue with the drugs. So, in the first trimester, it is usually avoided, and but if we are going to operate, if it's an operable, then we can operate that malignancy and go ahead with the drugs. For the breast cancer, patients, depending on the stage and her general condition, everything, we can operate and give her chemotherapy and simultaneously also during pregnancy. And for radiation, we can wait till she delivers, or we can go ahead with MPP and then proceed with her treatment. These drugs usually other drugs we have to give like uterine contractions, like these contract uterotonics like oxytocin and all, we usually give in labor, and it is a short duration, so it doesn't affect much the baby. And this tocolytic sometimes we have to give for a long period, like if it's a precious pregnancy, twin pregnancy, or cervical incompetence, so we give these drugs like calcium antagonist and all, calcium channel blockers, so that such drugs we give and to avoid the uterine contractions. So, and this beta symptom, they are this beta sympathomimetic drugs. So they, for in such conditions we have to check for the heart of the baby also. Insert and Maxwell, it can be Maxwell is usually given. It's also given in preeclampsia and eclampsia, but it is also given as a neuroprotective to the baby, and tocolytic also. So And sometimes if an intrauterine device is there, then also we can remove the device if it is accessible, or we can go ahead and continue the pregnancy with the device in situ. Hormones, usually this bromocriptine and cabergoline, usually we don't need to give hormones, but if she's having some like prolactinoma and we need, or if she's already on that, if she has high levels of prolactin and on that drug, if she gets pregnant, then we can continue the drug. Thyroid, this is most common. We give the drug thyroid, this altoxin, levothyroxine, and if it is given at the beginning, it's usually like pre-T3 and T4. We have to check, and the dose might be increased like about 30% in pregnancy, and uh, after delivery, then she can go back to the previous low dose of altoxin. So, if hyperthyroidism is there during pregnancy, then we can give the drugs, carbimazole and propylthiouracil. It can be given safely during a first trimester, and this PTO is preferable. And this thiamazole, carbimazole in the first trimester is to be avoided, and second trimester it can be given. For parathormone, usually we avoid treatment of, in such conditions, but if required, if she wants to terminate, then we can treat and continue. Steroids are also usually steroids are anyways helpful, like near term they help in the lung maturity also. Then we can give steroids to such patients. And if the mother is taking high doses of glucocorticoids during the 8 to 11 week of pregnancy, we have to check for the cleft lip and cleft palate in such patients for any other reason if she has received. So for diabetes also we can monitor insulin. We can give it safely, long acting, short acting, and oral also medications which can be given safely for diabetes. Glucagon can be given during pregnancy at any phase when there is a severe hypoglycemia. So it doesn't transfer because the molecule is bigger, so it doesn't cross into placenta. Rarely there is any indication for estrogen. Um, but sometimes accidentally the patient is already taking oral contraceptive pills, and maybe if she has missed some pills and then she has conceived, then we can continue that such pregnancy. Mm. So this is the like for contraception, we have to, if there is a failed emergency contraception with ulipistal, we can continue pregnancy in this also if there is a contraception failure. Androgens, as already told, they are anabolic and they are contraindicated. Cyproterone and danazol are also absolutely contraindicated during pregnancy, and a risk of it can be terminated such pregnancies. Clomipene also we don't need to give it during pregnancy, but it can be an unplanned if she's already on clomipene and conceives in high dose. Anesthesia also, usually we avoid these halogenated anesthetics for the baby. It causes respiratory depression, it causes hemorrhage to the baby, and nitrous oxide is an ideal inhalation for the anesthesia and other obstetric procedure. Like if the patient we need to operate during second trimester for any other, for like for appendicectomy or for cervical encephalopathy, so then this halogenated should be avoided. Nitrous can be given. Propofol and thiopentol are among the drug of choice in general anesthesia, and uh, mm, it causes other drugs. If a large dose is required, or if a long surgery is there, like for malignancy also we can operate, then we have to be careful about the depressant effects to the baby. And we have to check, like if the patient is getting operated, we have to check the fetal heart rate and keep a watch on it and the blood pressure and all. So this ketamine, it is contraindicated in pregnancy if we want to continue. Like if we are giving ketamine during cesarean, then it's fine. But if you want to continue the pregnancy, means it's any other surgery apart from cesarean, then we have to avoid that drug. Local anesthetics can be given, like all the lignocaine, lidocaine, bupivacaine, and all they can be given safely, and they are usually given in small doses also. For the skin disorders also, usually the whatever drugs are given, they are local. So local drugs can be given. Alcohol derivatives are also safer. And only for pimples and all, like acne, this retinoic acid, it should be avoided. Quinolones also are to be avoided. Like they are given in leprosy and all. Tacrolimus is to be avoided. Topical use of anything can be given. Keratolytics. And for psoriasis and all, we can give all these azelaic drugs. Sulfur drugs can be given. UVA, UVB light treatment, that is also considered safe in pregnancy. And this fumaric acid, it is not recommended during pregnancy. And if accidentally found, then we can continue. Retinoic, I have already told. So this also for condyloma, acuminata, this cryotherapy, these are safer, right? PCA application, they are the treatment of choice during pregnancy. And warts, they can also be treated with salicylic acid, cryotherapy and all. And for lows and all, whatever treatment, the dimeticon and the local topical application, they are also safer. Permethrin is also safe for this infection. Deodorants can be used. This Clostridium botulinum toxin should not be used during pregnancy. Even sometimes it is used in cosmetics and also it should be avoided. And it can cause hypertension and also growth retardation to the baby. Abortion also if it is first trimester. This finasteride and minoxidil, they are also contraindicated and they should be avoided in pregnancy. So this was the last slide where like for the husbands, they are the 50% of the gene comes from the husband. And nowadays the awareness is also increasing that the males are also exposed to all these agents. Whatever happens to females, they can also be on some anti-neoplastic drug or get exposed to some things. So theoretically, there can be three things like if uh, cytostatics, like it could damage the sperm itself genetically or impair the spermatogenesis or the maturation of the sperm. And it is also possible that the substance may become attached to the sperm and get transported during fertilization in the oocyte, like whatever drug. And the agents in the semen may undergo resorption through the vagina. Vaginal like mucosa, it is highly vascular, so it can get resorbed in the blood and then reach the maternal circulation, and it can affect the future baby, like the baby. And the metabolites found in the female are mostly much lower concentration, but still it can, there is a possibility that it will affect the baby. And sometimes after conception also, they directly reach the embryo or fetus, these whatever agents through the semen. So I think that we should consider a male partner also in whatever, like how we have studied all these drugs to be avoided. So there should be something for males also to be avoided if they are planning pregnancy. It should not be only for females if it is a planned pregnancy. So that was my last slide. It was
Yeah,
a
thanks a lot, ma'am.
vast topic. Yeah.
Yeah, it was. And I can see Dr. Krishna Priya calls it an encyclopedia, which I completely agree with. And I'm sure all doctors agree as well, seeing their hearts and thumbs up. Definitely, ma'am, you have kept it very elaborate as well. And thank you so much for the session. So, ma'am, do you have some time for the questions? Is that okay with you?
Yeah, we can go.
All right.
For hydroxy, somebody has asked, I think Rajendra Purohit. Hydroxychloroquine can be given during pregnancy. So if the patient is already on that, then we have to continue, but we should not start it during pregnancy. It should be avoided. But if the patient was already on that, then we can just monitor and depend. Always it is risk versus the benefit. If we have to, if it's a precious pregnancy and the patient is willing to continue, there is a risk of HCQ. But then we have to continue such, we can continue such pregnancy also, but preferably don't start it fresh during pregnancy. Then, are any medication side effect causes TDH? TDH? No. TDH, I don't remember any medication. Does placental extract help to counter the side effects of discussion drugs when simultaneously? Placental extract is usually given locally, no placental extract. So whatever local things, topical things are given are safer. Cardiac anomalies, Turner syndrome is the issue of which group of drugs? So this phenytoin and all these can cause Turner syndrome, cardiac anomalies. Turner syndrome is itself a chromosomal anomaly actually. It's an X0. It is associated with cardiac anomalies. And these anti-epileptic drugs, they can also cause cardiac anomalies. Safe MDR, TB drugs. So all the drugs are safe for coughs except this streptomycin. We should avoid streptomycin. Destol, rifampicin, ethambutol, everything is safe. Which drug is responsible for leaking membrane in early period of pregnancy? Leaking membrane is always because of some infection. So, because the membrane gets ruptured or damaged at some point because of the infection. So, whatever drugs like mostly this immunotherapy like biologics, which will decrease the immunity, which will make the patient prone to sepsis. Such drugs will the chances are more of causing PRO, premature rupture of membranes.
Ma'am, you can take the last question as well, and we can continue on the comment section later.
Okay, safe analgesic for labor pain. For labor pain, yeah, epidural analgesia is given, labor analgesia. So they give this bupivacaine and all that can be given safely.
Oh.
That's it. Lot of questions are there.
Questions, and definitely
I'll answer it.
Definitely an important topic as well. So we will get to all the questions. Ma'am, sometime this week we'll get in touch with you and we'll try to answer all these questions right here in the comment section. So, and ma'am, thank you so much for your time today. You went all the way ahead of your time to spend so much, to give us so much information as well. So thank you so much.
Yeah, my pleasure.